Assalamu alaikum warahmatullahi wabarakatuh. So we were discussing about the management part of this deep venous thrombosis. Let us continue with that topic. We had discussed till the management like initial therapy, advanced therapy, initial therapy, anticoagulation. In that we have discussed NOSCs and bridging. What drugs require parental bridging with heparin, fondaparinux or unfractionated heparin. So in which patients catheter-directed thrombolysis and IVC filters are required, and duration of therapy. Normally it is 3 months. If the factor is persistent, then it is indefinite for life. On in cancer patient, it is also for life. And we had discussed about this algorithm of management from McMaster textbook of medicine. So here we have learned that if the patient has high or intermediate risks with well score, then we will take some basic laboratory tests like CBC, blood group, APTT, INR, and creatinine, and we will directly start on anticoagulants whether if there is no contraindication, and later we will confirm with sonography. In low patients, after confirmation, you should treat the patient. If there is any contraindication to anticoagulation, then IVC filters are recommended. Okay. And if there are no contraindications, then you will start the anticoagulation therapy. Anticoagulation therapy will be in two ways. One is directly you give the drugs without any bridging by parenteral IV agents, and second one is first you will give a bridging therapy with injectable agents like low molecular weight heparin and or unfractionated heparin or fondaparinux. After this, you will give other drugs like it can be warfarin or non-warfarin anticoagulants. Okay. Now let us learn uh, what is the dosage and how you will give in different conditions these things. So anticoagulation of venous thromboembolism, you can divide it into non-warfarin anticoagulation and warfarin anticoagulation. Okay. So first of all, non-warfarin anticoagulation. So you can use unfractionated heparin, bolus, and then continuous infusion to achieve a APTT of 2 to 3 times the upper limit of the laboratory normal. So PT and either APTT should be more than 2 to 3 times of upper limit of normal, or APTT, or PTNR should be 2 to 3. So till that time you will, for 2 days it should be. Okay, when you are using unfractionated heparin. So what's the dosage of this unfractionated heparin? So it is 5000 international units TID. This is the dosage. Okay. So other thing is, so this you need to give TID. Okay, in treatment. Enoxaparin is low molecular heparin. This you give BD, twice daily dose, 1 mg per kg. Usually 40 mg BD or 60 mg BD it is given. If the patient has normal, provided the patient should have a normal renal function. If the patient does not have normal renal function, then you should use unfractionated heparin because of its short half-life. Second kind of category of LMWH is dalteparin. So it is used at a dose of 200 units per kg once daily, or 100 units per kg twice daily. Again, provided the renal function test should be normal, because it is a no molecular weight heparin and the duration of action is prolonged in CKD. Okay. So 200 if take in a 60 kg patient into 200, if you do 60 kg, 2 6 are 12, so 12,000 units you will give dalteparin. 12,000, or you can 10 to 12,000 units, 12k units once daily OD dose you will give is dalteparin. Okay. One more is that tinzaparin. Okay, that is 175 units per kg once daily, again with normal renal function test. Okay. So other one is fondaparinux. This is also weight based once daily. Again, the renal function test should be normal, or the dose should be adjusted according to the EGFR. So that's about the unfractionated heparin and low molecular heparin and how you will give with dosage. So this is unfractionated. These three are low molecular weight, and this is fondaparinux. Okay. Other thing is direct thrombin inhibitors. So they are argatroban or bivalirudin. So when they are used with suspected or proven heparin-induced thrombocytopenia. So if a patient has history of heparin-induced thrombocytopenia or developed heparin-induced thrombocytopenia, then you can't use this heparins. Okay. So then at that time you can use this direct thrombin inhibitors, that is argatroban and bivalirudin. Bivalirudin is more used commonly. Okay, so these two are novel oral anticoagulants which are used, which do not require any monitoring. Okay, so how they are used? How they are used? Rivaroxaban 15 mg twice daily for 3 weeks. Then it is followed by 20 mg once daily with dinner meal after 3 weeks. Okay, 15 mg twice daily for 3 weeks, then 20 mg with dinner meal after 3 weeks. Next is apixaban. So it is used at a dose of 10 mg twice daily for 1 week, followed by 5 mg twice daily thereafter. So this is OD rivaroxaban. You can use after 3 weeks. You can use it as OD dose. And apixaban, it is twice daily. BD dose it should be used. Apixaban. So for the first week, it is used at a dose of 10 mg twice daily. That means 20 mg daily. Okay. And then after 1 week, it is 5 mg twice daily. 10 mg twice daily for 1 week, then 5 mg twice daily. And rivaroxaban is 15 mg twice daily for 3 weeks, then 20 mg with meal, night time. Okay, dinner meal. But these are some costlier drugs, rivaroxaban and apixaban. Okay, remember this point. Now some other like dabigatran. So these are this is also a what do you call thrombin inhibitor. Okay, so but this requires these two, dabigatran and edoxaban. As I discussed previously, dabigatran and edoxaban require 5 days of either unfractionated heparin or low molecular heparin or fondaparinux. Then it is followed by dabigatran 150 mg twice daily, or in some books it is given the dose as 150 mg BD or 220 mg per day. Okay. Edoxaban, again, it requires 5 days of unfractionated heparin, low molecular heparin, or fondaparinux, followed by 60 mg once daily. Again, provided the renal function test should be normal and weight should be more than 60 kg in the absence of potent P glycoprotein inhibitors. So, what are the condition of edoxaban? The renal function test should be normal and weight should be more than 60 kg. You can use it as once daily. That is the advantage. Edoxaban 60 mg. Okay. Bivalirudin in patients who have heparin-induced thrombocytopenia. Okay, that's about non-warfarin anticoagulation. We have discussed in this heparin and NOACs and dabigatran and edoxaban. Then coming to the warfarin anticoagulation. Again, it requires 5 to 10 days of administration to achieve effectiveness as monotherapy. So bridging therapy is required here. Full dose of unfractionated heparin, low molecular heparin, or fondaparinux as bridging agents when initiating warfarin. Continue the parenteral anticoagulation for a minimum of 5 days until two sequential INR values at least 1 day apart should achieve the target INR range. Usual starting dose of this warfarin is 5 mg. Remember, this is 5 mg, and you can titrate if this INR is not achieved. Okay, 2 to 3 is the INR target. So starting dose is 5 mg. Okay, that's about warfarin anticoagulation. Then how you will give? So this is a simple chart which shows how to give. Okay, so normally the treatment is 3 to 6 months. Okay, so bridging therapy is normally 5 to 7 days. That is given parenterally. For which agents? For warfarin and for dabigatran and for what do you call that thing? Edoxaban. For these three, you require bridging therapy. Then you will start either a vitamin K antagonist or other anticoagulant, meaning warfarin or non-warfarin. Then you will continue either for unprovoked or reversible factor for 3 to 6 months, or indefinite for cancer patients or a persistent factor. First 5 days of parenteral, which is discovered in patients with receiving vitamin K antagonist if INR is more than 2 for more than 2 days. Parenteral treatment is not used in patients who received rivaroxaban and apixaban. So this does not require any parenteral treatment. What are the parenteral agents? LMWH, UFH, fondaparinux. Okay. Dabigatran is started after 5 to 7 days of LMWH, whereas the difference is these two are started after the parenteral treatment, whereas warfarin is started along with the parenteral treatment. That we should know. Okay. Warfarin is started along with parenteral treatment. These two are started after the parenteral treatment. Okay. That is the thing. For pregnancy, in pregnancy, LMWH is preferred. Cancer patient, again, LMWH is preferred. UFH is preferred in kidney patients, or you can also use yes, UFH is preferred. You can also use NOACs. Depending upon the EGFR, you will adjust the dosage. Some special considerations. Okay, so pregnancy is especially the obesity, isolated cough, deep venous thrombosis, and post thrombotic syndrome. Four things. Okay. So in pregnancy, LMWH is the drug of choice. NOACs and warfarin are contraindicated because they cross the placenta, increase the risk of teratogenicity, and fetal risks are there. LMWH does not cross the placenta. It requires dose adjustment with weight gain. Anticoagulation often continued throughout the pregnancy and 6 weeks postpartum, meaning throughout the pregnancy and during the perpural period, you will give LMWH. And LMWH is given IV only. Okay. Okay. Obesity, the main important thing is weight-based dosing is required in obese patients. NOACs are generally safe up to BMI of 40 kg per meter square or 120 kg. Beyond these limits, meaning BMI of 40 or more than 120 kg is the weight, beyond these limits, clinical judgment and monitoring is required. Okay. Obesity risk increases the risk of venous thromboembolism recurrence. Consider anti-10A monitoring for LMWH in morbid obesity. Empiric management may require higher doses or preference for warfarin. Okay, empiric management. Okay, so one important thing here is anti-10A factor monitoring is required here. Okay, for low molecular weight heparin in morbid obesity. Okay, and the safest are NOACs in these patients. Main thing to remember in obesity is weight-based adjustment of the drugs is required. Okay. Then isolated calf DVT, I said no. So if the tibial veins are involved, only tibial veins, distal DVT you call it as. Okay, proximal nothing is not. Popliteal vein is not involved. Femoral vein is not involved. Iliac vein is not involved. Just a distal isolated calf DVT is there. Then you will not give treatment for those patients. You will do a serial imaging for 2 weeks, and when you will treat if the thrombus propagates proximally. That is the way of treatment. Many cough DVTs resolve spontaneously. Anticoagulation is reserved for extension or high risk patient, for example cancer patient and immobility. So in two conditions you will give anticoagulation in isolated cough DVT. That is if the thrombus extends towards the proximal veins in during serial monitoring by sonography, or if the patient is high risk patient. High risk, the patient should be high risk, like cancer or immobility for more than 3 days. Another thing is post thrombotic syndrome. So what is that? That is chronic, nothing but chronic venous insufficiency leading to swelling, pain, ulceration. Compression stockings not routinely recommended for prevention. I said no. Prevention, they are not recommended, but when they develop active symptoms, they are helpful. Compression stockings are helpful. Post thrombotic syndrome develops in up to 30 to 50% of proximal DVT cases. Early mobilization and adequate anticoagulation reduces the risk of post thrombotic syndrome. Stockings can improve the quality of life in symptomatic patients, not for prevention. Some upgraded, so these are the four things, special things we should remember. One is pregnancy, where LMWH should be used. Okay, obesity, weight-based treatment should be there. Calf DVT monitoring is required, and if there is thrombus propagation, you will use anticoagulation, or if there is high risk DVT, then you will use anticoagulation. Post-thrombotic syndrome, compression stockings are not recommended routinely for prevention, but if they develop post-thrombotic syndrome, then compression stockings are useful for decreasing the symptoms. Okay, and chances of getting post-thrombotic syndrome is more after iliofemoral DVT. That is these are the things. Okay. Some upgraded things: cancer associated thrombosis, LMWH or NOAC preferred, indefinite therapy often required. Renal impairment, unfractionated heparin or warfarin may be safer than NOACs because there is increased tendency to bleed in these patients. Okay, so these two are the important drugs in kidney patients: unfractionated heparin or warfarin. So warfarin usually requires bridging therapy. So unfractionated heparin as bridging and warfarin as long-term anticoagulant can be used in renal impairment patients. Elderly patients, the thing is there is higher bleeding risk. So careful duration planning is required. Okay. Multidisciplinary care is required in obstetrics, oncology, hematology input for complex cases. Renal impairment and UFH and warfarin. Elderly patients, high bleeding risk. That's about all about the management of deep venous thrombosis. Okay. Now we'll see prophylaxis is a very important topic in patients with deep venous thrombosis. Many patients require prophylactic anticoagulation. Okay, so you can divide prophylactic to for prevention of VTE. You can divide the patient as high risk surgery, medical patient meaning hospitalized patients, and long haul travel meaning uh, passenger travel of more than 7 hours in flight. Okay, that is called as long haul travel. So at that time also they have a high risk of DVT development. So in high risk surgery you can use prophylaxis, for example LMWH, UFH, or even NOACs. Okay, in hospitalized patient you will use LMWH, UFH for those with reduced mobility and a PADUA score of more than or equal to at least 4. So remember, in hospitalized patient for any medical condition, so you calculate some score known as PADUA score, PADUA score, and if at least the score is if at least the score is 4, then you will give prophylactic treatment to those hospitalized patients. In long haul travel, you will not use anticoagulation therapy. Ambulation and cough exercises are recommended. Compression stockings are required for those that are at higher risk. So these things you can do in long haul travel. So prevention of venous thromboembolism among hospitalized patient. Okay. So first we will see the PADUA score. Okay. Then we will see the doses, because PADUA score assessment is important in hospitalized patient. So this is the PADUA score. See here, active cancer patient has a score of 3. History of VTE except for superficial and thrombosis, again it has a score of 3. Immobilization, okay, for more than 3 days, against 3 score. Previous diagnosis of thrombophilia like deficiency of antithrombin, protein C, protein S, factor V Leiden, prothrombin gene mutation, antiphospholipid syndrome, again it has a score of 3. Recent meaning less than 1 month of trauma or surgery, it has a score of 2. Elderly patients, heart failure, respiratory failure, MI, stroke, infection, rheumatological disorder, obesity more than 30 kilogram per meter square, hormonal therapy, all of this, how many? 1, 2, 3, 4, 5, 6 condition carry a score of 1, and these 4 condition carry a score of 3, and this one thing recent meaning less than 1 month of trauma or surgery carry a score of 2. So this in this way you can remember it easily. So 4 conditions have a score of 3, 6 condition have a score of 1, 1 condition have a score of 2. So you can remember it as uh, A hit mnemonic. A hit. Okay. A hit is nothing but active cancer, H for history of VTE, I for immobilization, T for thrombophilia, diagnosis of. Okay. H for history of VTE, I for immobilization, T for thrombophilia, A for active cancer, or you can remember it as something mnemonic, easy mnemonic, chit. Okay, it is a chit. C for cancer, H for history of VTE, and I for immobilization, and T for thrombophilia. And these are comorbid conditions. Every comorbid condition carries a score of 1. Elderly 1, heart or failure, respiratory failure 1, MI or stroke, vascular event 1, acute infection or inflammation 1, obesity 1, hormone therapy 1. So score of at least 4 has a high risk of VTE. Then you will give what do you call prophylactic anticoagulation treatment in these patients hospitalized. Now we will move to this table. Venous thromboembolism prevention in hospitalization. So for high risk surgery, see surgical patients, high risk non-orthopedic surgery, heparin 5,000 units subcutaneously, BDA TD. So once is required in enoxaparin. This is more commonly used. Dalteparin 2,500 or 5,000 units once daily. This is given as twice daily. This is given as once daily. Medical oncology, cancer patient. So PADUA score will be 3 here, okay, 3. And if they're immobilized, again 3 plus 3, 6. Enoxaparin, dalteparin, rivaroxaban, apixaban. But remember, in cancer patient, LMWH is preferred. You can use NOACs also. Cancer surgery, including gynecological cancer surgery. Again, enoxaparin 40 mg daily, 1 month of prophylaxis is required. Major orthopedic surgery, you can use warfarin target and 2 to 3, enoxaparin 40 mg daily, dalteparin 2.5k or 5k daily, fundoparinox 2.5 mg daily, rivaroxaban prophylactic dose is 10 mg. Okay, prophylactic dose of rivaroxaban is 10 mg daily, beginning 6 to 10 hour post-operatively. Aspirin also can be used. Okay, aspirin, remember, 80 to 325 mg daily. Dabigatran 110 mg first day, then 220 mg daily. Oh, so prophylactic dose is 110 mg, treatment dose is 150 mg. Okay. Apaxaban prophylactic dose is 2.5 mg twice daily, beginning 12 to 24 hours post-operative. So rivaroxaban, the treatment dose is 15 mg BD followed by 20 mg Nocte. This is the treatment dose. Whereas prophylactic dose is 10 mg OD, 6 to 10 hours post-operatively. Apixaban treatment dose is 10 mg, 10 mg BD, and then 5 mg BD after 1 week. This is after 3 weeks. Okay, but you do it half. So meaning the maintenance dose is half of the maintenance dose is the prophylactic dose. So 10 mg is half of the maintenance dose, 2.0 mg is half the maintenance dose. That is the prophylactic dose. Medically ill patients, especially if immobilized. So that is about high risk surgery patients. This is all about high risk surgery patients. Medically ill patients, especially if immobilized with a history of previous VTE with an indwelling central venous catheter or with cancer but without active renal ulcer. So these are contraindications, remember, to anticoagulation. Without active gastrointestinal ulcer, major bleeding within 3 months, platelet count less than 50,000. Again, heparin, enoxaparin, deltaparin, fondaparin. Medically ill patients about to be discharged from rivaroxaban, prophylactic doses 10 mg, 10 mg OD, okay, daily. Apixaban 2.5 mg BD. Anticoagulation contraindicated because of presence of these conditions. So where then what you will do? You will do intermittent pneumatic compression (IPC) devices. By these devices you will do intermittent pneumatic compression. By air compression you will do, or compression stockings are effective in medical patients remains uncertain. So compression stockings role is uncertain, but intermittent pneumatic compression role, it has a role. Okay, where you have active bleeding, you can't use anticoagulation. For example, a hemorrhagic stroke also, there also intermittent pneumatic compression is recommended. Okay, so that's about the dosages of drugs which are given for prophylaxis. This is from Harrison. Okay, what was score you remember in medically hospitalized patient? Okay, see, this is from McMaster. If you have a ischemic stroke with impaired mobility, then you can use anticoagulation. Okay, impaired mobility should be at least more than 3 days. Okay, prophylactic dose of LM 40 mg OD, 5000 BD UFH. Okay, or you can use IPC or graduated compression elastic stockings in patients with contraindication to anticoagulation treatment. You can safely use a prophylactic dose of heparin in combination with aspirin. Dose of heparin with aspirin. So aspirin, if it is there, then no problem. Okay, but do not use heparin in the first 24 hours after thrombolytic treatment of stroke. So if thrombolysis is done in this patient, so for first 20 to 24 hours, you should avoid doing anticoagulation treatment in these patients. Or if anticoagulation is planned, don't give thrombolysis if planned, don't give anticoagulation. Hemorrhagic stroke. Hemorrhagic stroke is very critical matter because already there is hemorrhage active bleeding. So use intermittent pneumatic compression in early treatment. In clinically stable patients at very high risk of VTE, you may use LMWH at prophylactic dose or subcutaneous UFH 5000 IU BD on day 2 to 4 after the bleeding if considered safe. What safe? There should be a cessation of bleeding after 2 to 4 days. Okay. In hemorrhagic stroke, if the patient is high risk for thromboembolism, how you say it, high risk, PADUA score should be or well score you can take. Okay, well score now. Well score is for DVT. So PADUA score is there. If the PADUA score is more than 4 or at least 4, so after 2 to 4 days, you can plan for anticoagulation in these patients also. Only if bleeding is if the bleeding is ceased. Okay. The time for starting heparin administration depends on the evaluation of risk of thrombosis and the risk of recurrent bleeding in these patients. So this McMaster text, this importance of this is taking stroke in particular. So how to do anticoagulation in stroke patients in particular. In previous this Harrison just we have discussed about surgery and medical patients. Okay, here it is mainly concentrating on stroke. In detail it is given. Okay. Now again same hospitalized acutely ill medical patients at high risk, meaning PADUA score more than 4. Same LMWH, UFH, fondaparinux. In case of bleeding or high risk of bleeding, use IPC or graduated compression elastic stockings. Use pharmacologic prophylaxis during the patient's immobilization or hospitalization. Long-term immobilized patient remaining at home or in an institution. Do not use VTE prevention routinely. So only a patient who is immobilized in the hospital, you should use prophylactic anticoagulation therapy. If the patient is immobilized elsewhere other than hospital, you don't require VTE prevention routinely. You will give treatment if the patient develops thromboembolism. Okay, that is one important thing we have learned here. Okay, so for the treatment of stroke, anticoagulation stroke, in detail this chart explains how to give anticoagulation, when not to give, when to give. So one important thing that you should rule out is ruptured Baker's cyst. So what will be that? There will be sudden cough, pain and swelling, often mimics DVT, ruptured Baker's cyst. Cellulitis, there will be fever, chills, erythema, warmth, muscle strain, localized pain, often activity will be there. These are important. So cellulitis, Baker's cyst, and one more is filariasis. You should differentiate. Okay. DVT to avoid unnecessary decoagulation. Imaging helps. Okay. Now we have learned about the doses of anticoagulants. What if anticoagulants cause bleeding? So we should also know the antidotes of these anticoagulants in order to treat the patients if they develop bleeding. Okay, bleeding. So what are those antidotes? Bleeding management. Suppose if heparin is the culprit, then protamine sulfate is the antidote of choice. It neutralizes UFH and partial reversal for LMWH. What is the dose of this protamine sulfate? For UFH, 1 mg of protamine will neutralize 100 units of heparin. That means 50 mg of protamine sulfate will neutralize 5000 units of heparin. Enoxaparin, 1 mg of protamine will neutralize 1 mg of enoxaparin. That means 40 mg of protamine will neutralize 40 mg of LMWH. You may repeat 0.5 mg per mg if bleeding persists in case of LMWH. Okay, protamine sulfate. So if you are a beginner, then just remember protamine sulfate is the antidote for heparin. No need to remember the dosages. These are helpful clinically. Bleeding management for dabigatran. For dabigatran, remember the antidote. It is idarucizumab. Idarucizumab. It is a monoclonal antibody fragment. Complete reversal you will get. So what is the dose? 5 gram IV, 2 consecutive IV bolus dose you can give, or you can use as infusions as 2.5 gram, 2 infusions separately. Okay, 5 gram IV. So what is the antidote? It is idarucizumab. Now these are very much used. Apixaban, rivaroxaban, less likely to cause bleeding, but if you develop bleeding, then what is the dose? It is undexanet alpha. Undexanet alpha. It is a recombinant modified factor 10A decoy protein, binds and sequesters 10A inhibitors. It will bind the inhibitors. Low dose regimen, high dose regimen. This is the dosage. Okay. Choice depends upon the agent, dose, time of last intake. Additional notes. Okay. Supportive measures should be taken along with this antidotes. Okay. What are those? Stop anticoagulant, apply local hemostasis, transfuse blood products if needed, and in transfuse vitamin K, give vitamin K injection along with plasma concentrate for warfarin reversal. Not primary here but relevant. Always balance reversal with risk of thrombosis. You should consider. Monitor coagulation labs and clinical status closely. So that's about the antidote of drugs. For heparin, it is protamine sulfate. For the bigatron, it is idarucizumab. For uh, fundabrinox and apixaban, it is andexanet alpha. And for warfarin, it is vitamin K with plasma concentrate. This is a summary of whole things which we have learned. Okay, I will just turn the page color. Sorry. Okay, you just see here. This is the summary. DVT definition and epidemiology we have discussed. Okay. So it is a spectrum of deep venous system thrombosis, VTE spectrum, 1 to 2% of hospitalized incidents, risk of pulmonary embolism. Pathophysiology we have discussed. In that, Virchow's triad is important. Inflammation and nets and atherothrombosis interaction, meaning arterial thrombosis is linked to venous thrombosis. In Virchow's triad, three things: stasis, endothelial injury, and hypercoagulability. So that was pathophysiology. Risk factors can be divided into genetic, acquired, indwelling catheters. Genetic are factor V Leiden, prothrombin mutation, okay, protein C, S or ND3 deficiency. Acquired are cancer, obesity, pregnancy, estrogen, smoking, hypertension. That's about risk factors. Clinical presentation: cough, pain and swelling, unilateral cough, uh, difference of more than or equal to 3 centimeter, pitting edema, Homan sign is not specific, not reliable. So some specific fogs like alba dolens and cerulean dolens. So this is emergency. Diagnostic workup: well score first you will calculate, then D dimer and imaging. In imaging, venous ultrasonography, MR venography, contrast fellow phlebography. Management: you will have anticoagulation, advanced therapy, and duration. Anticoagulation, NOACs like rivaroxaban, apixaban. Parenteral bridge is required for warfarin and dabigatran and edoxaban. Okay. Okay, advanced therapy, catheter directed thrombolysis. This is for cellular dolens. Okay, IVC filters. Duration: provoked DVT is for 3 months, unprovoked DVT for indefinite. Special considerations: pregnancy, LMWH is the choice. Obesity, weight-based dosing is required. Isolated cough DVT monitoring is required. Post management of post thrombotic syndrome we have discussed. Prevention, surgical prophylaxis we have discussed. PADUA score for medical patients. Okay, and travel exercises and compression for long haul travel. So that's about the summary of whole topic of venous thrombosis. Thank you.